The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone, and welcome to our Friday edition of our Safe Income webinar series. This is Deanna Mitchell with Leading Age Michigan. This past week, and especially these past 2 days, have been, well, really amazing, for lack of a better word. And I'm not sure about you all. I think you probably feel it too, but I feel like I've been drinking out of a fire hose. I also want to note before we get started that there's 1 or 2 questions I believe that we have not responded to from Wednesday's webinar. And I apologize because the Q&A are behind. It's been so much just to keep up with what's new. It's hard for us to do that. But it's my goal to have that up to date by the end of today or over the weekend for sure. So welcome, and we have a lot to talk about this morning. Dalton will be exploring fair housing issues during the pandemic, and the rest of the presentation pretty much centers on testing. I do encourage non-nursing home providers to participate in the discussion about antigen testing because I think it's information that might be helpful to them, if not now, in the future. And toward the end of the presentation, we will move to the updates that are specific to the nursing home requirements. So at this point, we will turn the presentation over to Dalton, our Director for Advocacy.
Good morning, everyone. Thanks for attending today. As Deanna said, we'll be covering fair housing issues first in our advocacy update. And then we'll be talking about some issues that came up with the Family First Coronavirus Response Act, specifically relating to FMLA and employees taking time off to take care of individuals who have had a school closed. And then we'll be talking about some PPE grant opportunities in the state, and then the nursing home specific provider grants that I'm sure some of you have heard about. Before we begin, I wanted to discuss a little bit about our annual Leadership Institute. This year it's going fully virtual, and we're really excited to try out a new format and see how everyone enjoys it. Our conference this year is specifically focused on access to the experts and policymakers who can help inform new visions for the future. Knowing that 2020 is an election year, we have developed sessions to deliver pertinent state and legislative updates, budget, financial, and reimbursement trends, as well as regulation guidance, innovation strategies, and networking opportunities. We want to help members overcome, preserve, and continue to provide the quality care for which we have come to be known for throughout the state. This slide here highlights a couple of our speakers. We'll have an update from Director Gordon, Robert Gordon of MDHHS. The invited, he has accepted, he is no longer invited. Larry Horvath will also be providing an update, Director of LARA. And we'll also be getting an update from Dr. Alexis Travis, who's the Senior Deputy Director for Aging and Adult Services Agency. And we're very excited to have all these speakers speak today. Or at the conference, excuse me. So on to fair housing. I'll say early this week, I don't remember the exact day, Leading Age held a fair housing call for Leading Age members that featured HUD compliance expert Heather Staffs from Star Momentum Compliance Consulting. And she provided fair housing guidance on a couple of practices that have been affected because of the COVID-19 pandemic. She focused mostly on reasonable accommodation, limited access policies, mask requirements, and notifications to residents. And we'll start off by looking at reasonable accommodation on the next slide. So what was her advice to providers? She said that you will want to manage your reasonable accommodation requests according to your pre-pandemic best practices, and that people have been seeing an increase in reasonable request accommodations across the country because of the pandemic. Mostly these have been focused around requests for emotional support animals, exceptions to community mask requirements, late rent payments due to hospitalization, and the installation of grab bars. Regarding limited access policies, she suggested that they be based on COVID-19 recommendations from CDC or requirements by state and local officials. She did an important recommendation that she stressed was posting notices on the entrances requesting that people do not enter if they've been exposed to COVID-19. She also noted that recent HUD FAQs allow for the closure of common areas or reduced management office hours. As for mask requirements, which is where a lot of people have been struggling, especially HUD providers, she said that they can consider this a reasonable accommodation request and ask for medical documentation or self-certification, and that some providers have amended their housing rules with a mask requirement or some have had existing provisions in their lease or community rules. About the topic of issuing lease violations for non-compliance of these mask requirements, she really stressed that you check with your legal counsel beforehand. And of course, she always suggests focusing on the behavior and not the person engaging in the behavior. And as always with fair housing, I'm sure many HUD providers know it's important to stay consistent and reach out to local health authorities if this becomes an issue. Her last point of emphasis was on notification to residents. She stressed that resident privacy is still paramount even during the pandemic, and that personally identifiable information about COVID-19 or disability status should never be communicated to other residents. And what she said is that residents cannot be required to let you as a provider know if they have contracted COVID. And then if you do become aware if they have contracted COVID, you have to notify other residents without linking it back to the person. So she suggested posting notices at the entrances that explain what the precautions are and say that there is a risk to the community. And that is all her guidance was focused on for that call. I thought it was very insightful and good for those who have been struggling with fair housing during a pandemic, as that can get kind of tricky. Moving on, and thanks to our members who brought this to our attention, we covered this act in late March. This is the Family First Coronavirus Response Act, known as the FFCRA. And this act requires employers to provide their employees with paid sick leave or expanded family and medical leave for specified reasons related to COVID-19 until December 31st, 2020, with some exemptions, including healthcare providers. And we'll explore what qualifies as a healthcare provider later. At least how it's written right now, those exemptions are pretty broad for what is a healthcare provider. But I just wanted to go through some of the basics of the act here. For all employees, they get 2 weeks of paid sick leave at the employee's regular rate when the employee is unable to work because of a quarantine or experiencing COVID-19. They also get 2 weeks of paid sick leave at 2/3 the employee's regular rate of pay if they are unable to work because they need to care for an individual subject to quarantine. The most important here is for employees employed for at least 30 days because they qualify for an FMLA leave. And this act makes it so that they qualify for an additional 10 weeks of paid expanded family and medical leave at 2/3 of their pay, where an employee is unable to work due to a bona fide need to care for a child whose school or care provider is closed or unavailable for reasons related to COVID-19. And for purposes of this act, a closed school includes a school that has switched to online learning. So if your school district has switched to online learning, this act comes into play, and you may see some staff members using this act to apply for family medical leave. If we, And so I just wanted to give everyone, these are the reasons qualifying for leave. You could kind of break them out on that last slide, but here they are in an ordered list for you so you can see them. They're subject to a quarantine. They've been advised to self-quarantine or isolate themselves due to COVID-19. They're experiencing COVID-19 symptoms. They're caring for an individual subject to an order in 1 or 2, which means they're caring for an individual who's quarantined. 5 is the tricky one. They're caring for a child whose school or place of care is closed for reasons related to COVID-19. And then the last one is that they're experiencing any other substantially similar conditions specified by a couple of departments. So here's a nice list for you to see who qualifies for these leaves. We'll move on to who qualifies for a healthcare exemption here. You'll note it's a fairly large list, and they left the terms fairly broad. They aren't defined specifically in the Act. And so what we have to go off of is that a nursing facility, retirement facility, nursing home, or any similar institution, employer, or entity is covered for a healthcare exemption, which provides special accommodations for healthcare providers, specifically around qualification 5, caring for someone in a school. And it's important to note that this also includes any permanent or temporary institution, facility, location, or site where medical services are provided. So it doesn't necessarily have to be a full-time employer here. So the complications, as you probably have figured out, is that employees can request off for caring for a student who's going back to school. School starts for a lot of people, I think, in a week or two. So you may see an uptick in people requesting this leave, but as a healthcare provider, you are exempt from the Act. But does that mean it's an all or nothing kind of thing? Does that mean you exempt yourself from employees being able to go to take care of a student who can't attend school and is attending online, and then you can't provide them with these enhanced COVID measures? The Act does specifically say this, says that this can happen. You can exempt yourself from the school portion of it alone, and then still keep the COVID-19 protections in place, because the guidance specifically says that it wants to minimize the spread of the virus associated with COVID-19, and that healthcare providers who are exempt should be careful and judicious, excuse me, when making these decisions, and then can choose to provide them paid sick leave in a case of their own COVID-19 illness. But there have already been legal challenges to this in New York. And the next slide shows the rulings there. Sorry, really dry today. The court in New York made a ruling that says the definition of who qualifies for the healthcare provider exemption is too broad. They mainly focused on the idea that, I'm sorry, I'm getting, I think, an echo from myself here, that it covers all employees employed, and it also covers contractors employed. And the courts thought that that was a little bit too broad. You'll also see that the second point that they ruled on is that it affects contractors or employees who aren't directly employed by the healthcare provider. The third point is the requirement that employees secure consent for intermittent leave for qualifying reasons. Underneath the Act, a person has to provide their employer notice before they take this leave. The courts were concerned about that. And the last is that point that I just made as well. And Leading Age is reaching out, and we'll be seeking an opinion on the matter because we think this is really important going into school season when a lot of school districts, especially the major ones in Michigan, have opted to go online. Moving forward, we're discussing PPE grant opportunities. We're going to be discussing a couple of grant opportunities here. The first one that I think everyone's kind of anxious to hear news about is the one that was created in Senate Bill 690. This is a PPE grant fund of about $25 million that's designed to help cover the cost of COVID-19. Specifically, the grant covers PPE, COVID-19 testing, and COVID-19 testing equipment. And this applies to eligible purchases made in response to COVID-19 for purchases made after March 1st, 2020. Eligible providers for this grant include a wide variety of healthcare providers, long-term care facilities, home health care, and congregate care facilities are the most notable for us. There is the full list right there. And if you remember about this, what was going on with this grant is that the bill itself doesn't actually define what these terms mean. We have worked with the department to help establish these definitions, and you'll notice on the next slide that we have heard they are very, very close to finishing the application for providers, and we'll expect to see it soon. Our advocacy team has asked the department, as I said, and we've got a response yesterday from Kate Massey. These are her specific words here. She said, "We are finalizing the application and terms for the program and may have the application available today or tomorrow." And that was speaking about yesterday. So they're planning on having it available today. We'll see, these things often get bumped to Monday or over the weekend, but either way, it'll be in our hands soon. It says the person who's been working on the program has been working hard and has been creating the application as well as the supporting material, an FAQ, et cetera, to help stakeholders manage through the process. So we'll be getting the actual application and an FAQ hopefully around the same time when this comes live, so everyone can start to apply, as $25 million isn't a lot for all those provider types. So you want to make sure that you get this grant application submitted quickly, and we'll be sending that out as soon as we hear about it via our various means of communication. Our next provider grant fund opportunity, I'm sure a lot of people have heard about, but this is the federal grant that is being distributed into nursing facilities bank accounts this week. That's $2.5 billion in total being released to nursing facilities across the nation. The amount is calculated on a base amount of $10,000 plus $1,450 per bed. So you should be able to do some rough math to figure out how much you should be seeing within the week here. This grant is intended for testing, PPE, staffing, and training. And CMS referred to the money in a press kit released this week and hopes to help support the increased staffing requirements that they've put on nursing homes. This is the second amount that has been distributed from the CARES Act. There was $4.9 billion distributed in May. So this is the second wave of funding from the CARES Act. And other provider grants have been distributed to all Medicare and Medicare facilities. And then the other portion of the monies are intended to be used to reward high-performing facilities who have had lower number of cases compared to the local community transition. None of that money, however, so far has been tied to any of the training mandates that we have heard in previously spoken about by the president. So what we're talking about is the extra 2.5 out of the $5 billion that was allocated here. Before we begin to questions, I do want to talk about one last grant opportunity that those who attended the nursing facility provider check-in call earlier this week, I think it was yesterday actually, they discussed there. We haven't received feedback from them yet, so I don't have a slide as nothing is set in stone, but we know that the department is looking to provide a grant application process for capital plant projects specifically focused on COVID-19 and facilities ventilation units, specifically upgrades to those ventilation systems or buying HVAC filters, those kind of things. So they're looking to invest money into facilities to make them better at infection control from a ventilation standpoint. They did say that this money will be about $22,000 per facility who applies, roughly there. So. But the problem with it is that, their intent was to apply it to skilled nursing facilities. They then said that they were using CARES Act dollars to fund this grant. And if you use CARES Act dollars, you can't just make it only for nursing homes. There's some rules in there that they have to follow that they need to double check on and see if this grant application can move forward as they initially envisioned it.
All right, thank you very much for that, Dalton. Before we get to any questions, Leading Age Michigan wants to thank our business partners for their continued support during the pandemic, and we encourage you to take a look at the names of the organizations up on the screen. These are the organizations that continue to support the association and your organizations as well. Without their continued support, the Education Foundation would be unable to be as dynamic and innovative as we are. Therefore, when you are considering a purchase of goods or services, please remember this page of logo, or this name of logos, I guess I should say, and then the logos throughout the webinar, and consider making a purchase from one of these fine organizations. It looks like I just have 2 questions right now, so let me grab those really quick. I assume.
Blake, can I interrupt for a moment? Blake,
Yep.
I would like to clarify something that Dalton just said. I do believe that the department can focus this CARES Act additional funding for ventilation and other system approaches to COVID on nursing homes. What the question is whether or not they should only allow those grants to Medicare and Medicaid certified providers. So we know that there are some unlicensed members out there who are affected by that. So that question was specifically raised during the meeting, and they said they would take it back and look at it, because this is not Medicaid money, it's not Medicare money, it's CARES Act money. And so we are hoping that they expand that eligibility across the entire group. We would like to expand it across the entire continuum, but the issue in discussion was really about whether or not you had to be Medicare and Medicaid certified. So I'm sorry for interrupting. Go ahead, Blake.
Thanks, Deanna.
Oh, you're fine, Deanna. So let me grab those questions. All right, the first one is, I assume the protection of COVID status is the same for team members as residents.
I don't know about Dalton, but I'm not sure. I'm not sure what that specifically is asking. Dalton.
I assume they're talking about the FFCRA.
I think it was something to do with one of your beginning slides with possibly notifying.
Oh, for fair housing.
Possibly.
Yes, I believe so.
Okay. Let me grab the next one. Regarding the new provider relief grant funds, the state is currently reimbursing nursing homes for testing. How does this affect the payout, if at all?
I can take this one, Dalton. I believe that it doesn't affect the payout at all. I think that you can use some additional monies for testing, but you don't have to. So I think that Michigan has actually been somewhat fortunate in its ability to fund and actually require testing that other states have not required. So I think that the monies were suggested as a support for testing because a lot of other states are in a different situation than we are. As far as we know, and we believe that the current, at least for the near future, the state is going to continue to reimburse testing for nursing homes in Michigan.
Okay. It is our understanding that the FFCRA guidance for granting FMLA for employees, etc., is only for employers less than 500 employees.
That is correct.
All right. And it looks like that was the last question, so we can go ahead and move on.
Okay, thanks, Blake, and thanks, Dalton. So we're going to just have a brief review of our situation, looking at the U.S. and in Michigan as of the data that was obtainable as of yesterday. So I think this graphic is one of the better heat map kind of pictures that describe the cumulative caseloads across the country. This is a CNN graphic based on Johns Hopkins data. You can see that the intense caseload areas mostly occur in the east and in the high population states. And Michigan, while having significant numbers of cases overall, because we had a huge number of cases in the beginning of the pandemic, currently is now being dwarfed by other areas such as Chicago, New York, LA, and the Northeast in general. The cumulative caseload for the U.S. is listed here as of yesterday, but we also want to note that the July average of 70,000 cases daily has really improved in August to about 40,000 cases. I mean, that's still a lot of illness, but overall the U.S., even though there are spikes in certain areas that are significant, is on the decline. So if you remember early in the pandemic, we had several graphics that talked about the amount of time that it took for the number of cases to double. And I can distinctly remember hoping to move that needle for Michigan from 1 to 2 days to at least 1 week. At this point, we are doubling our numbers about every 3 months. And so that's really a marked improvement over time. And this graph kind of shows the updated time to double. So for Michigan, we're running number 18 in the number of cases, the 18th highest among states across 56 entities, because they include all of the territories as well in that. And we have to remember that this is based on Johns Hopkins reporting as well, and the numbers don't jive with Michigan reporting because they include the probable cases. For cases per population, we're doing pretty well, much better than in the beginning. We are down to 37 among those 56 entities. The problem is that we are still 9th highest among states in overall deaths and 9th in deaths per 100,000 population. So that continues to be a significant issue here in Michigan. So here's our standard 7-day rolling average graph, and we still see somewhat of an upward trend, hopefully only for the short term. We'll have to see if that levels out again, hopefully soon. The next graph shows our 7-day average daily death rate, and it has finally started to trend downward a little bit over the past several days. So we're going to end this section with our MySafe Start map as posted as of this morning. And it's not changed since last weekend. We are still in high-risk areas, have high-risk areas on the east side of the lower part of the state. And as we've discussed over time, we believe that these areas are too large to be meaningful drivers for the level of restrictions in nursing homes. We have said that in countless venues with the state and other policymakers. And now we are waiting to see what MDHHS will do, because CMS, as we will discuss later, is mandating nursing homes look at the positivity rates per county, and at most a county around them if necessary, to identify their testing requirements. So we will talk more about those requirements later. We did ask MDHHS specifically on Wednesday what their plans were, and they, of course, have not really had a chance to figure that out. But we anticipate that there's some changes on the state side coming down the road based on the CMS new guidance. So now we're going to get to talk about antigen testing and the rapid turnaround in thinking that has come out from CMS, the FDA, and the CDC as well. So we're going to start with a brief review of the original CDC guidance that was issued about 1 or 2 weeks ago. Antigen testing currently is described as a diagnostic test rather than a screening test, and is still considered best for diagnostic testing because it identifies positives well, but not necessarily negatives so well. And in other words, there's a lot of false negatives. Let me be clear about that. And recommendations had been, the original recommendations had been designed for its use to rapidly confirm the presence of the virus in a symptomatic person. They're less expensive and they're very quick, but they are less sensitive than PCR tests, and they produce a lot of false negatives. They're also known to be most accurate within 5 days or so of onset when the viral loads are greatest. So this original CDC guidance did state that they can be used for screening in nursing homes if you are doing repeat and ongoing testing. In other words, you would be continuing to test negatives on an ongoing basis without the need for a confirmation using a PCR test. But the original CDC description of antigen testing also included that there was limited information on the use as a screen in high congregate settings. So their pretty much bottom line was that the gold standard was and is still noted to be the PCR test. And if you do need to do a PCR test to confirm a diagnosis based on an antigen test, you must do it within 2 days, or it's not considered a confirmatory test. So we all know that the federal government is shipping POC equipment and kits to every Medicare and Medicaid nursing home in the U.S. That has a CLIA waiver, and it's expected to have them all distributed by the end of September. Earlier this week, the FDA updated its Q&A on testing to support the need for a highly sensitive test, such a PCR test, to be used, but only if you can get the test results back in 48 hours. They point out that there's little value if the test turnaround time is much longer than that, and we all know that that's been a really huge problem here in Michigan. So if it's not feasible to do a PCR test and get the results back in a timely manner, they find that a point-of-care test may be the better option, and providers can use them for that purpose. But it also depends on the fact that you need to do serial testing. Otherwise, there's no follow-up to those potentially false negatives that you could be getting. Positive tests, can you go back one, Blake, please? I think positive tests in general are still considered to be probably accurate. And we'll talk about potential inaccuracies and how to think about that a little bit more later. But negative tests are still at best considered presumptive, and clinicians will have to consider them looking at the overall context of the situation, symptoms, transmission rates, etc. So you can move on now to the next slide. So because these tests have a number of false negatives, if you are in the middle of a significant outbreak or someone has high suspicion of an infection, you should confirm any negatives with a PCR test. So if you have someone in your facility or you have someone who has symptoms and they come out negative, then you should really be confirming those negatives with a PCR test. But it's not necessary to confirm negative testing if you're just doing routine screening. So if you're trying to diagnose and you have negatives at a time when you think someone might probably be positive, or you have outbreaks in your facility, you should confirm them with a PCR test. So the link to the guidance is here. And as of earlier this week, we know that the government has issued about 5,600 machines and anticipates that the rest will be coming in the next month. And remember that those are only going to go to Medicare or Medicaid certified homes with CLIA waivers. So if you don't have a CLIA waiver, you might consider working on that. And in the last day or so, the federal government has also just publicized a deal with Abbott for an even cheaper and easier point-of-care test. It's important to remember that there's some training required, and some of the infection control experts are concerned about facilities' ability to collect the specimens and report accurate results. But we all know that we're doing specimen collection now anyway. But if there is anyone on this call today who has some experience with training or manufacturer training or has some experience with the test, we would like to hear about that during the Q&A. So yesterday afternoon, the CDC also updated their thinking on antigen testing, and they developed a whole new web page for that called Considerations for Antigen Testing. So in that, they say that rapid tests can augment other efforts if PCR testing is unavailable, or if you're having delay in reporting. And when they say delayed reporting, they mean anything more than 48 hours. So they confirm a lot of what they said in their first guidance, but they they do lay out the expectations of use for screening in congregate settings and when the tests will have to be confirmed using a PCR test, and they don't always have to be confirmed. So there's a lot of different scenarios about that. If a symptomatic person tests negative, you should continue transmission-based precautions until a PCR test results are available. And if you have asymptomatic staff in a facility, in an area where there's low community transmission and they test positive, they should be excluded from work as a precaution, but they should be retested with a PCR test as well. And of course, you have to report all your findings to state and local officials as you do now. One of the things that they do want to warn against is use of an antigen test that could be used as part of a test-based strategy for return to work or discontinuation of transmission-based precautions. That is an inappropriate use of the test, and you have to use PCR testing if that's absolutely needed. So this is the diagram of how to think about use of this test, and I think this diagram is done pretty well and pretty clear. For testing of symptomatic residents or staff, and those are on the left side of the screen. If an antigen test is positive, you of course continue transmission-based precautions, or if it's staff, they should be excused from work. And if the resident or the staff are the first positive test in the facility, you should start an outbreak response immediately. So you can assume that if indeed you have symptomatic residents or staff and you have a positive antigen test, you trust that test. If you're testing symptomatic persons and the test is negative, you still need to keep them in isolation-based precautions and or exclude them from work if they're staff, and follow up with a PCR test. You want to consider the need for the test based on which point of care test you're using, because some are a little bit more accurate, but pretty much you should be following these up with a PCR test if you're finding symptomatic persons who test negative because of the number of false negatives. So if a person has recovered in the past 3 months and developed, go back. Oh yeah, please, thanks. If a person has recovered in the past 3 months and develops new symptoms, alternate diagnoses should be ruled out before you do any testing. Testing of asymptomatic residents or staff, which are more on the right side of the graphic, and the test is negative. Testing of asymptomatic residents or staff in a nursing home is part of an outbreak. Let's go there. If the test is positive, you don't need a confirmatory test. You continue transmission-based precautions, or you excuse from work. So if you've got cases in your facility and you're testing asymptomatic residents or staff and you find a positive, you're going to assume that's positive and act on it that way. If it's negative, they still believe that residents, if it's a resident, they should be placed in whatever appropriate precautions you have for a facility with an outbreak, considering where the outbreak is, etc. And staff can continue to work with close continued symptom monitoring, but you still have to continue serial testing every 3 to 7 days until no new cases are identified for a whole of a 14-day period. If you're not having an outbreak and you have testing with asymptomatic persons, if it's positive, you want to perform a PCR test within 48 hours. Because if you're not having an outbreak and you might be in an area of low incidence in terms of the virus, you're going to question whether or not that's a real positive. So you want to confirm that with a PCR test. And you should continue to exclude staff from work until test results are completed. So if that test is positive, you're going to, of course, assume it's positive until you know better. If it is confirmed by the PCR test, you have to keep the staff, of course, home, and you have to initiate the outbreak response that you would expect. If the confirmatory PCR test is negative, you need to discuss it with the local health department because that could be a little hard to figure out. The timing between the antigen test and the confirmation PCR test is important. And the antigen test's accuracy could be based on that timing. And lastly, if the antigen test is negative, allow staff to work, monitor for symptoms, and continue testing. And of course, remember that outbreaks are defined when any infection, new infection occurs in a staff or a resident in the nursing facility. So we're going to talk about testing and the new regulations for nursing homes a little bit later. We're going to break this up a little bit and talk about some more general items and review our executive orders. These are the current orders that have any real bearing on senior care programs. And of course, the two major orders that continue to be really directly impacting us are 156 and 169. And we call them the visitation policy, 156, and the regional hub policy, which is 169. Both of these you'll see are due to expire shortly. We do continue to be in a state of emergency also until September 4, and we expect that to continue at least, but we're hoping that the visitation policy will change based on the task force final recommendations that will be going to the governor by Monday. However, considering how the map looks, it'll be interesting to see what the epidemiologists ultimately recommend there as well. So the most recent guidance is 172, and that was listed, you can go ahead and move forward, Blake. 172, and that was listed at the bottom of the list. It extends the protections to workers who may be ill with a virus, but it also updates the list of symptoms to determine that. So a lot of 172 is a repetition of several previous executive orders. You have to allow persons with symptoms to stay home and use the CDC return to work guidance for them. Or if they've had close contact with someone with symptoms or a positive test, they must stay home for 14 days. For nursing homes, surveyors have been saying that any unexplained symptom in staff have to be addressed as suspicious for COVID. However, for workers in general, under this EO, only the principal symptoms are used as a guide to determine whether or not employees can be allowed to stay home. Note that those there are three principal single symptoms: fever, cough, or shortness of breath. And other symptoms, if you don't have one of those three, can also be used, but you have to have two of them: loss of taste or smell, muscle aches. These are not new symptoms, but the fact is that you have to have two of them in order to meet the criteria for needing to protect the work environment and stay home. And of course, when they talk about close contact and exposures, they're always talking about 6 feet, within 6 feet for 15 minutes. And of course, these requirements do not pertain to staff working in healthcare facilities, because the expectation is they're going to be exposed, but hopefully protected. Some quick reminders about the trainings. The CMS targeted training that was announced, I think earlier just this week. We talked about it on Wednesday. To be honest, I was really confused about the training notices I was getting from the QIO and the live bi-weekly sessions associated with the targeted training, and come to find out they're the same thing. The targeted training modules that are on the CMS website, remember there are 10 for managers and 5 for frontline employees. They are not the same as the QIO trainings in general, but the live Q&A sessions is a blend of CMS, CDC, and the QIO. And I did listen to the live Q&A session yesterday, and while some of the questions asked and it really was a question and answer period. Seemed kind of basic. I thought it was a very good program, and included a lot of information from Dr. Namalia Stone from the CDC, who took time to explain a lot of the current understanding about viral transmission. And we're going to talk a little bit more about that when we get to the nursing home requirement discussion a bit later. There is a NHSN training schedule for next week. They have updated some of their data elements. And yesterday, MDHHS reported that the EM resource platform for nursing homes now aligns with the CDC new requirements as well. So before we move on to nursing home focused information, we'll pause to take some questions.
All right, thank you very much for that, Deanna. Again, Leading Age Michigan just wants to thank our business partners really fast and give you that quick reminder that if you are considering a purchase of goods or services, please remember this page of logos and consider making a purchase from one of these fine organizations. This one is for Dalton. Did you see the press release that just came out on the PPE grant? It just came from Whitmer's office in my email. The application is in there along with an FAQ.
Yes, I'm actually in the process of saving that as a PDF and uploading it to the webinar. I was going to interrupt Blake after this question, but I should have that grant application. This is the $25 million from Senate Bill 690 I was referencing in today's call. I will attach this as a handout, as a PDF to today's call, and we'll be distributing that to members today.
All right, thank you for that. For the point of care tests, must they be performed using the nasopharyngeal method, or can we use the nasal Nayer's method of swabbing?
My understanding is that you can use nose, and I think some of them actually let you use a oral swab as well, but don't take my word for that. I do believe, my understanding is that they do not require nasopharyngeal testing. But remember to look at your manufacturer guidance. But I do believe that these don't necessarily require quite that invasive a specimen collection.
Okay. If staff wears masks the entire time working and then tests positive during routine testing, do the staff that had contact with this staff member have to stay home even though they all wore masks?
Yes, no question. If I understand this correctly, it doesn't matter which test you're using right now. If you find any positive, you have to act on it immediately. And even if you get a negative later, that doesn't necessarily mean that that was a false positive. In fact, guidance today from MDHHS that we're going to talk about later that was just issued this morning clarifies that you can never assume that a positive is false, and that you have to treat that as an outbreak, even if you have a negative test later, because there are false negatives. So if you get a false positive at any time, you must treat that person as if they are, I'm sorry, let me reframe that. If you get a positive staff person at any time, you treat that person regardless whether you think it's a false positive or not.
Okay. If a staff member is positive but worked with mask on prior to getting a positive result, do the residents need to go into precautions?
Yes, anytime you have any positive in your facility, you have to look at that and start going to outbreak mode. Now, you don't necessarily have to have 100% PPE for your whole facility. You don't necessarily have to quarantine everyone in your facility. What you need to do is evaluate where the outbreak's occurring, do a little bit of contact tracing, talk to your local health department. It's possible that you might shut down one unit. You might shut down half of your building. It depends on whether or not your staff has been crossing over. So it's a very individual decision you have to make if you do have an outbreak. But you do have to evaluate that and do something if you have any staff or resident test positive.
Okay, and then this is follow-up from the previous question regarding someone staff wearing a mask and then testing positive. She said, but do the staff who worked with that staff member have to be off work for 14 days, or can they monitor for symptoms and get tested?
My understanding is that you do not have to look at those persons as presumptive positive. But you want to talk to your local health department about that, because a lot of that might be based on the amount of outbreak in your facility or the local transmission. But it would be very much a hardship just to assume that all those persons were positive. They, of course, should be tested immediately. And probably a PCR test would be best. But considering the timing for that, you might want to do a rapid test, and you should bump up precautions. But no, they do not have to be sent home immediately just because they worked with someone who is positive, unless you know that there's been a break in precautions.
All right, thank you. And it looks like that is the last question, so we can move on to the next section.
Okay, now we get to the fun part. So for nursing homes, HHS issued new regulation on August 24th, but the guidance with the details was not really issued until Wednesday, and that was through QSO 2038, and it includes the details for that guidance, and the link for that is listed right here. So the new rule updated the Code of Federal Regulations to require nursing home testing of staff and residents under certain circumstances. And those circumstances are left up and detailed in the QSO and not the regulation. So the regulation, except for some CMP penalties, was really kind of bare. Those basic requirements are listed here, and they include things like testing is going to be required based on local situation, how you have to document results, how you have to report appropriate actions if you have an outbreak, etc. But there's no real distinctive detail in how to do that in the rule, but there is in the CMS memo. So the CMS memo detailed the requirements using either PCR or antigen tests for testing, but notes that facilities, again, must have a CLIA waiver, and they must be getting their results within 48 hours. If you're not getting results in 48 hours, it's highly suggested that you use point-of-care testing, or if that's not possible, you have to document coordination with local and state health departments. And we get a sense that the surveyor is going to be looking very closely at that. Because the thinking is that if you're using all these tests and it's taking you a week or two to get them back, it's really meaningless. And we've been kind of saying that to the state all along. So it identifies that facilities must continue to screen all staff at least each shift and residents every day. And it identifies which facilities are subject to testing, which in terms of testing itself, pretty much in alignment with Michigan, although there's some increased testing requirements as well. So the guidance includes a table that's replicated here, and it identifies the testing priorities expected under a new FTAG F886. Everyone with symptoms, of course, has to be tested. That's not new. Outbreaks are defined as any new case arising in any staff, whether or not staff are working in your facility and other facilities. If that person works in your facility, that is considered an outbreak. And of course, any resident within the nursing home, but not acquired elsewhere. If the resident positive, if they were admitted positive, obviously that's not considered an outbreak. For any outbreaks, you must test at least every 3 to 7 days until no new cases have been identified for at least 14 days. For routine testing for staff, there are some tiered requirements. Well, they're going to talk about those in detail later. And routine testing, of course, is not recommended for residents, and that's in alignment with what the state's doing as well. So for symptoms, there's really nothing new here. They confirm the need to isolate residents and staff with symptoms awaiting testing results, and there's a focus on the appropriate initiation and maintenance of transmission-based precautions. Surveyors are going to be looking at that. They have been looking at that. There have been citations about the initiation of transmission-based precautions or sending staff home on a timely basis and maintaining the full amount of time for maintenance of transmission-based precautions for seniors. So you have to remember, you pretty much need to use, for most of your people, a symptom-based methodology to discontinue those things. And surveyors have been looking at that very closely. So for outbreaks, again, nothing new. All residents and staff should be tested immediately if any new case is found in your facility. Remember that for positives, repeat testing is not required for 3 months. And of course, you have to use the usual criteria for return to work and discontinuing precautions for anyone you find to be positive. Now we come to the new part, the harder part. Routine testing based on the amount of community transmission. The levels of community transmission are going to be decided by the NHSN data. And the first set is expected to be published today. And it's based on a county rather than the large regions that we use. I did look late last night on the website to see if it was there. It wasn't there yet. I haven't looked yet this morning to see if it's there. It'll be interesting for us to look at because I really think that for most people, the kinds of testing you're going to have to do isn't going to change much. In fact, you might be less than 5% in some areas. MDHHS may still make you do it weekly, you know, so there has to be some understanding that the state has some control over this as well. But we don't know of many counties that have higher than a 10% positivity rate. There could be some. We haven't had a look at that data at that kind of level, in which case you're going to have to go to twice a week. So we're really looking for the impact of this. I think in other states this is dramatic because they're not testing. But in Michigan, overall, this may not affect us a whole lot more from the testing burden that we're already doing. So we'll have to see. If you don't have turnaround times, though, for PCR testing within 48 hours and you don't use PCR tests, you'll have to document all of those efforts to coordinate, to get that testing done on a timely basis with the local and state health departments, and the CMS surveyors are now going to be looking for that. The S&C memo states that facilities should update their plan. You have to have a testing plan based on county positivity rates, and they suggest every 2 weeks. And in fact, they suggest Mondays. If the county transmission rate increases to a level needing more testing, you're expected to start that immediately. But if the county level decreases so that less testing is needed, you must wait until the positivity rate has remained there for 2 weeks. But if you're really only looking at the numbers every 2 weeks, it could be longer than that. So, but you have to make sure that you maintain the level of testing that you're doing for 2 weeks before you change it if the county positivity rate has declined. Facilities who border other counties should consider rates there as well if the staff are crossing the line to work. And asymptomatic residents should only be tested if there's an outbreak, and facilities can consider routine testing for dialysis patients or chemotherapy patients if they think it's necessary. Staff with symptoms who refuse testing must be prohibited from the building until return to work criteria are met. I think that previous guidance from the state said they had to be placed in a non-direct care area. They have to be now prohibited from the building. During an outbreak, any staff who refuse testing must also be banned from that building. But if you're not in an outbreak, staff who refuse should be addressed based on local guidance. Refusing residents, there's a little new here, but asymptomatic persons must have closer monitoring if the facility has current cases in the building. So if an asymptomatic person is in the middle of an outbreak and refusing testing, you're going to have to document how you're monitoring that person, and I think surveyors are going to be looking for that as well. The memo includes some other testing considerations, but nothing very much new. You don't have to retest positive persons for 3 months. We know that. There's a recommendation that each facility consult with authorities and review all information about testing. I kind of took this verbatim out of the rule. It kind of overwhelmed me. It almost makes us all need to be infection control experts. But I just wanted to include it here to show you that there's a should. I don't know how they're going to look at this. This might just be in reality a recommendation. There's an awful lot of detail here about infection transmission. You still need an order from a clinician to test, including point of care rapid testing. And there's a list of resource guidelines about testing. Most of them we've all seen, but they are listed in the memo, and so I have listed them here as well. The memo also includes a focus on the need for safe and accurate specimen collection, but it doesn't go into the details. It does include the resources on that topic if needed. And I, of course, added those here. The memo does note that surveyors will not be reviewing adherence to actual CLIA requirements, but only whether or not, if you're doing point of care testing, if you have a current CLIA certificate. So that's the only part that they're supposed to be monitoring in that respect. The reporting requirements seem pretty standard, but they are detailed in the memo. You, of course, still have to report to NHSN. You still have to inform residents about new or suspected cases. That hasn't changed. For internal reporting, you must document all details of any cases that you find. Date of onset, potential contacts, testing, etc. for any positive cases. Resident cases have to be reported in their medical record. You have to document and log any of your routine testing. You have to log the respective county rates. And remember that you have to have a documented plan to do all this and policies as well. So now surveyors are going to be looking at that very closely. Here's a list of what the surveyors have been directed to look for. They're going to look for your log. They're going to look for your schedules. They will sample documents for residents and staff, including persons who tested positive. They will try to see how testing is done in real time if possible. And if that's not possible, they will interview your testing staff, whoever's doing testing in your facility. They will be looking at turnaround times and facility actions based on your testing results. And of course, the memo has more links to resources, but these resources are not new to us. The S&C memo ends with an updated infection control guide for focused surveys and focused surveys. And we were thinking about going through this today, but oh my gosh, it was overwhelming. There's a lot of red in these next pages that we strongly suggest you look at. We will look at that in detail, and if we think that it would be helpful, we will review them perhaps next week, depending on what else is in front of us. But there is quite a bit of change. I think it's mostly contextual. I'm not sure there's a whole lot of change in the requirements, but we have not had time to delve into it in detail yet. So the rest of the interim final rule, that's the actual regulation in the CFR that was put out on Tuesday, has some other requirements for nursing facilities as well. It details the CMP fines for not reporting to NHSN at $1,000, I'm sorry, $1,000 per first instance, and it will increase by $500 with each subsequent instance until the total fine reaches $6,500. I hear other press reports saying up to $8,000 per instance, but I can't find how that works out. That's not what it says in the guidance that I can see. There are no plans of correction needed for citations based on reporting, but facilities can appeal, and all the other same processes apply for these citations as they would for any citations. And the effective date of this rule is 8/25. So this is one of the rules that they don't have a comment period that extends the implementation date at all. Additionally, the rule speaks to the fact that surveyors can enter the building at any time, regardless of your outbreak status, if they want to. Ombudsmen, however, can be restricted if there is high transmission, but you still have to provide them some access to the resident. They also state that testing information has to be in staff personnel records, as well as your logs and schedules. You should have separate files for contracted employees. If you don't have separate files for these contracted employees, your contractor agreement is supposed to include a discussion of the process for documenting those results. The regulation goes back and ensures that facilities are taking direct and swift action whenever an outbreak occurs. Nothing new here. Your testing plan has to include all the necessary arrangement details about how you're going to get your testing done. And as part of your emergency plan, you obviously, this is not new, must have policies for the use of volunteers and a plan in case many of your staff become ill. And I think they're focusing on this right now, mostly because they're worried about that second wave coming. So, and again, there's always links to the resources that they link to in the memo. I'm sorry, this is the regulation, in the regulation. So that ends the discussion of the final rule and the associated survey insert memo. On Wednesday, we had some questions about testing, and I was not sure which of the many testing updates we were talking about. And the CMS memo with the details for the first set wasn't out yet. So I thought that persons were asking about this update from the CDC. And I still am not sure what we were questioning at that point, but this update from the CDC is quite controversial, in fact. It stated that testing was no longer needed for asymptomatic persons who have come into close contact with COVID, and it again defines that close contact. Remember that this is not necessarily in the context of a healthcare situation provider. This is just for anyone who's had close contact with someone who is COVID positive. So again, there's been a lot of controversy about this since it came out, and there's speculation that it was not initiated from the CDC, but perhaps from HHS. And in response, we've seen a lot of media about providers saying, well, this is ridiculous. We are not going to follow this new guidance. The WHO actually decided to continue its current guidance to test and isolate persons who've been exposed. And so this was overall quite surprising to a lot of people, since the CDC itself notes that half of transmissions, up to half of them, occur from asymptomatic or pre-symptomatic persons. So it didn't really make sense to a lot of infection control experts. So under pressure, the CDC yesterday changed the wording to say that rather than it's not recommended to test these people, that these persons do not necessarily have to be tested. But again, it looks like most public health systems are not following this new update. So before we end our presentation today, I want to take a moment and discuss a couple things that are very current. One is the recent communication from BCHS, the Bureau, and CMS Region 5, that all persons leaving the building have to be quarantined on return. This has been overwhelming to, I'm sure, all of our members and providers and us as well. We cannot find, after exhaustive search, any CMS or CDC guidance for that, although there is some indication it could have come out in a discussion or training at some point. But we believe that this only increases the isolation and the detrimental effects on residents that they already are experiencing with the visitation order. So a Michigan provider asked this specific question about this during the CMS call on Wednesday. And CMS kind of floundered around a bit, but they didn't get a confirmation that this is something that they should do. And in fact, they were kind of implying that it depended on the situation. And we also had another colleague reach out to CMS directly through email, and they got a real non-answer to it. And I attempted to have this issue raised during the Q&A live session yesterday that the CDC, CMS, and QIO was putting on. So Dr. Namalia Stone from the CDC definitely conflicted with CMS in her discussion about whether dialysis patients needed to be isolated on return and what their needs might be, and stated that there was no requirement to isolate these persons since there was no data that quantifies that they are at increased risk. However, we don't have anything clear from CMS about this. We're still attempting to communicate with them and the Bureau about what we think looks like a misinterpretation of the guidance. There is some CDC guidance that talks about isolating persons who are newly admitted and readmitted who are considered unknown in terms of COVID status, but we don't see anything where the CDC says that these persons are considered unknown just simply because they leave the building. So we're still struggling with that. Another last note is hot off the press. There was a new guidance this morning from the department on testing. However, it's not on the website yet. So, but it was sent out as a memo. Just a couple small things. Obviously, they're still going to have to look at their testing guidance to figure out what to do about all the CMS rules. That's not out yet. But they do confirm that there's almost no such thing as a false positive, and that even if you have a positive test followed by a negative test, you need to treat that person as positive. And the other new piece is that if you have staff who are working in multiple locations and they test positive, all of those facilities must report, because that staff person has been in each of those facilities. And so you kind of have to own that to some degree, whether or not they acquired it in your facility or not, they've been in your facility. I think the previous guidance said that you had to coordinate who's going to report. That's no longer the case. You're expected to report any staff member who acquires a positive status if they've been working in your facility. And that last guidance, still, hopefully they'll post that today, but it's not on the website yet.
All right, thank you very much for that, Deanna. Before we get into any questions, I am going to turn it over to Dalton as he has a little update he wants to give.
Hello, everyone, and hello again, I should say. I did post that PPE grant application notification to the handouts. I would like to thank our advocacy team, as many of our asks were included in the definitions. I would urge all provider types to take a look at this, as independent living, skilled nursing facilities, adult foster cares, home for the aged, and assisted living were all included as approved provider types for this grant. Independent living providers can get up to $1,000, or will get $1,000 per frontline facing FTE, and skilled nursing facilities, adult foster care, home for the aged, and assisted living will get $2,000 per frontline FTE. You do need to show proof of purchase, and applications are due by September 8th. And so that's kind of a tight turnaround there. I'm glad to see they included a deadline on there to give people time, so it's not kind of this rushed feeling of applying and you won't get funding. So I do encourage everyone to take a look and please apply. The actual application seems to be fairly simple, but I haven't had a lot of time to delve deeply into it yet. So please download that or check your email if you haven't received that notification. It contains a link to an FAQ and a link to the actual application.
All right, thank you very much, Dalton. Now we do have a decent amount of questions here, so I'm just going to dive right into those. This one is more of a comment. They said, I looked the NHSN county positivity rate data is there this morning.
Oh, wow. Okay, great. We'll be looking at that.
All right. If we are testing a vendor equipment delivery person to allow them in the facility weekly, but they are not staff, does that have to count as a staff member?
I'm not sure exactly what you mean. If you're asking if you have to count them as positive, if you're testing them as part of your facility, yes, you do. I don't know how else you would count them as a staff member, but yes, you do. You have to test anybody who comes into your facility often, at least weekly, and report.
Okay. Deanna, have you heard more about the AG visits per the executive order and in what settings these visits are occurring? We heard it included AFC and HFA. Can you confirm?
Well, I don't know if I can confirm. I do know that they plan to follow up in more than just nursing homes, so I would assume any kind of senior care residents where there's issues could be included. But I have not heard of any cases where they've shown up. And in fact, if anybody knows of any, please let us know. I don't know. I've not heard anything. Dalton, I would ask you, have you heard anything about any AG visits and investigations?
I haven't, which was rather strange. I was in the actually a team member at Leading Age was sitting in for me at the Attorney General's Elder Abuse Task Force this week, and they didn't mention anything about this at all. They were largely focused around guardianship and banking issues once again, and so I will make an effort to bring it up in the next task force meeting or contact some people over there.
Okay. We are hearing they are giving multiple misdemeanors and bringing Laura in. Can you confirm?
No, obviously we can't confirm yet, but we'll definitely try and get more information about that.
All right. Someone says table 1 testing summary under routine testing for residents. What is considered routinely leaves the facility? I'm trying to figure out what that means.
Routinely leaving the facility, if you're talking about the CMS regulations and guidance that just came out, means someone who goes out for dialysis or chemotherapy or has some sort of regular appointment. If you're talking about the CMS Region 5 Bureau directive, they're talking about anybody who leaves the facility for any reason and comes back. But in terms of routine leaving, they're talking about scheduled frequent appointments for dialysis, chemotherapy, maybe infusions, etc., like that.
Okay. What about if you learn that test process was not correct when getting positive results and having follow-up negative results right away, 48 to 72 hours?
Well, because there's almost no test process problem that we could identify unless the only thing is if something was contaminated. That would be the only way I think that you would have a false positive for most of the tests, almost all of the time. And the requirements still from both the CDC and the department say you cannot assume that that person is not positive simply because they have a negative test later. So you do have to treat that person as if they're positive and do the full either transmission-based precautions and or return to work criteria for them. It doesn't matter if you think that there's something fluky or not, because the risk is too great for the residents.
Okay. We are in a county with less than 5% positivity, which allows monthly testing of staff. Based on the county data set, which is available today, does this override the current MDHHS weekly requirement based on Michigan regions and not counties? Will we see revised MDHHS guidance soon, and must we wait for that?
First of all, the answer about does it override what the state wants? No. You have to continue weekly testing, and I actually think this is probably going to be true for most counties until MDHHS decides what to do about that. I would consider the CMS requirements a minimum with the ability of the state to add on to that. The only thing the state can't do is tell you you don't have to do what CMS is telling you to do. I don't know when we're going to get guidance. Often it takes the department a long time to identify how they're going to react to something. So they could have guidance next week, or it could be a couple weeks. We don't know. I think that they are kind of overwhelmed by it from their response on I guess, yes, Wednesday when I asked them that question. I think they're going to have to adjust it a little bit. And I don't imagine, just knowing, being experienced in talking to the department and watching the governor and the epidemiologist, I don't imagine that they're going to let you go down to monthly testing, even if you're under 5%. But, you know, we could be surprised. But at any rate, the answer is no. You still have to do weekly testing at least, and you have to do more testing if you're in an area with higher transmission rates as well. So I'm sorry to have that bad news for you.
Okay. So do I or don't I place a resident in isolation quarantine after a doctor's appointment or procedure at the hospital while we are waiting for clarification?
Well, of course, you know, you need to make your own decisions about how you're going to attempt to follow the rules, but I think that it would be risky not to. You would be facing a citation as we understand it from the surveyors if they are investigating that specific case. So the answer is yes, you have to do that based on what CMS Region 5 and the Bureau is telling us right now. We continue to argue about it, but they have not changed anything.
Okay. How is the governor calculating an FTE for the grant? Our nurses work 72 hours and considered an FTE.
I have to throw that one to Dalton.
It's a frontline FTE. It is spoken to in the FAQ. I think it's a frontline FTE counts as a 90-hour week. I don't remember. I didn't write it in my brief notes here. It is definitely on the FAQ, though. It's one of the main questions on here. Give me a sec. Go on to the other question, and I'll answer that in a second.
Okay. I thought if a person was not on your floor 8 hours in a week, you did not have to test them like a maintenance person that just comes on your unit to pick something up and leaves.
Can you repeat that, please, Blake?
Yeah, no problem. I thought if a person was not on your floor 8 hours in a week, you did not have to test them like a maintenance person that just comes on your unit to pick something up and leaves.
Okay, well, my understanding was, at least I don't have any written guidance that says the 8-hour rule. My understanding was that if someone shows up in your building at least weekly, you had to include them in your testing, or at least ensure that they're tested somewhere and document those results. I think that there is still a focus in the guide for persons who show up weekly. The words are actually, they should be prioritized. So I think that at a minimum, you would have to continue to test anyone who shows up in your building weekly. And also consider whether or not you have an outbreak going on, or there's levels of high transmission around you, to think about whether or not you need to test other people who are perhaps not entering your facility quite as routinely.
All right. This one looks like more of a comment. There was a press release yesterday that indicated a few corporations out of the Brighton area.
Yes, I do remember that. I don't remember the details of that. I did hear that they had some problems with the Attorney General. Now that you remind me of that, I don't know the details of that, and I'm not sure whether or not that has anything to do with issues being forwarded to them by Laura, or whether or not it's part of that AG piece or something else. I would have to look into that a little bit more. We'll do so. I'll talk to Dalton about that a little bit later.
All right, now I am going to open up the mic of Dave Herbal. He has a few comments. It looks like you might be self-muted, or oh, you're on a couple times. I need to figure out which one is you. Okay, you should be good. Yep, you should be good now.
Yeah, just two comments on the Attorney General and the complaint aspects of things. So it's really working in two ways right now. The Attorney General has sent some cease and desist letters to senior living corporations out of the Brighton area and some other communities around Michigan for organizations that have been charging seniors a COVID add-on fee. I think it was $900 that the article mentioned. So, you know, they're certainly positioning themselves sideways with her office right now. And then on the flip side of this, I do know that Laura has received some complaints around organizations that are not following protocol. And Larry himself has gone out on at least the first couple investigations, and the Attorney General's office actually went with them. So they're serious about what they've put out in the press. So just wanted to bring you up to speed on that. And thank you, Blake.
All right, I'm going to go ahead and mute you back up, Dave. Can you explain the comment about informing the state if you can't get test results within 48 hours? Who has to do this? Where are you supposed to report? And where is this requirement coming from?
The requirement comes from CMS and HHS. I think that there's a lot of concern about the fact that test times are too long and making a lot of the testing results negative. I mean, not negative, not helpful. I do know that you have to coordinate with your local health department to attempt to get testing. That's a little bit more frequent. And I assumed it was your state health department because that's what is suggested in the guidance. I do not have the any contact information for the State Health Department off the top of my head. I would also send an email to the MDHHS COVID address as well. I don't have that off the top of my head either. I think it's something like MDHHS-COVID-19. But we can certainly get that out to people via the listserv or in the Q&A. I do intend to update the Q&A today if all goes well. But you do have to notify both local and state people. I think because the testing that they're requiring and all of the costs and resources going into testing, they feel really are not helpful unless you're getting those results back within 48 hours.
On to the back to the FTE question. It actually, I see why there's a question. It actually doesn't specify what they define an FTE as. So that is a question we'll reach out and ask.
All right, thank you, Dalton and Deanna. It looks like that was the last question. So if anything else does pop up in your head after this, you can go ahead and shoot an email off to Safe and Calm, or you can go directly to Deanna, Dalton, or Laura Funch. All their emails are there. You can also find our emails on our website, leadingagemichigan.com or leadingagemi.org, excuse me. So I believe that will end it. We would like to thank Dalton, Deanna, and Dave there for hopping on for a second. I believe we also had around 75 members and participants that took time out of their busy schedules to join us for today's webinar. We appreciate everything you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. Again, if you need the PowerPoint, that is attached here, and also the PPE grant application is there as well that Dalton attached. Deanna or Dalton, do you have anything else that you'd like to add?
Just everyone have a good weekend and hang in there. We'll have to see what next week looks like. Hopefully it'll calm down a little bit, and hopefully there won't be a second wave, but we'll see how all of this goes. So good luck, everyone, and God bless.
Have a good weekend. Thanks for attending.
All right. Thank you, everyone, and have a great rest of your day.